Okay, so like I said, I'm Dr. Amy Beaumont. I work at the University of Miami. I'm the coordinator of the Autism Spectrum Assessment Clinic. And today we're going to be talking about cognitive behavioral therapy for individuals who are on the autism spectrum. So I want to talk about, first of all, autism spectrum disorders, just a very brief overview, and the particular difficulties that they are presenting, and then an overview of cognitive behavioral therapy, and then who would benefit most from CBT, or cognitive behavioral therapy, the rationale for this particular therapy style for children and adults with autism spectrum disorders, and some of the strategies that are typically utilized, and then last, what to look for in a therapist. So autism spectrum disorders are really a neurological developmental disorder and characterized by impairments in these three different areas: social interactions, deficits in communication skills, and restricted or repetitive behaviors and interests. Okay, I'm having some technical difficulties. So autism covers a broad range, it's a broad spectrum, and so we're encompassing here autistic disorder, pervasive developmental disorder not otherwise specified, and Asperger's disorder. Let me see if I can go back. And so autism and these disorders fall under this umbrella of autism spectrum disorders. The Rett's disorder and the childhood disintegrative disorder are really considered more medical diagnoses, and so we're really going to focus on the other three: autistic disorder, PDD, NOS, and Asperger's disorder. And so in addition to those three areas of impairment, the social, the communication, and the repetitive or restricted interests and behaviors, we have some additional characteristics that are really common in individuals that have an autism spectrum disorder. So, and again, this is not in every child or adult with an autism spectrum disorder, but these are definitely things that we do see fairly often and that need to be addressed. So there's motor clumsiness, and that could be with fine motor skills like poor handwriting. It could be with gross motor skills, so difficulties jumping or hopping on one foot or riding a bicycle. The slow processing speed, and so a lot of times individuals on the spectrum process information a little bit more slowly, especially verbal information or language, and that can really impact a variety of things, but social interactions in particular, because when we have conversations, it's really a pretty quick back and forth. You say something and I want to be able to respond quickly and in a way that communicates what I want to communicate. And so if your processing speed is a little bit slow, it makes it difficult. It's like you need a few minutes to process what the person said and then come up with some response and then, spit it back out. So the other thing that we see a lot is executive dysfunction, and these are like those ADHD symptoms. So trouble concentrating or overfocus. So a lot of these kids have great concentration and attention when it's with something that they like, computers or trains or maps. But, as far as concentrating on schoolwork and more boring stuff, we see some difficulties with the concentration and also shifting attention. So transitioning from one task to another is difficult. And then distractibility. And we also see some of that hyperactivity and impulsivity as well. So a lot of times we see kids that present with these ADHD symptoms, and they're really just subsumed underneath the autism diagnosis. They just fit right into there. So another thing that we see a lot is anxiety and depression, and especially in the kids that are a little bit older. And I think often when kids are a little bit, and adults are more aware of what their difficulties are, we tend to see a little bit more depression. And then we see difficulty with judgment and problem solving. So really not great critical thinking skills. Difficulty conceptualizing to a larger whole. So these guys are pretty detail oriented, but then seeing the big picture is sometimes a challenge. And then sometimes the social motivation is decreased. And that's certainly not all of the time, and not for all children and adults, but it's something that we want to consider in doing therapy with individuals who are on the spectrum. So the interventions that we typically recommend for children with autism, and it's really for children, is applied behavior analysis, verbal behavior, which is a subset of the ABA, school-based methods like the TEACH method or LEAP, speech therapy, and these all have evidence, research and evidence that are backing them. And then there are, those towards the end of my list don't have quite as much research that supports their efficacy, or it's mixed. And so there's occupational therapy, floor time therapy, the gluten-free, casein-free diet, sensory integration therapy, relationship developmental intervention. And so these are all interventions targeted to decrease problem behaviors and improve better language or play skills or fine motor skills, social skills. But they don't so much address like the anxiety and depression, or not so much with the ADHD. So we want to look for interventions that will address those issues. And so when we have somebody that has anxiety or depression and the ABA doesn't address it and the speech and language therapy doesn't address it, what do we do? Comorbid psychiatric disorders are typical in the clinical presentation of autism spectrum disorders over time. Depression and anxiety are the most common. Some people suggest that anxiety and depression symptoms are common among autism spectrum disorder just in general, and then others believe that these problems are more common in higher functioning individuals or those with Asperger's symptoms. So the rates of depression among individuals with autism and Asperger's syndrome vary widely from study to study, with the highest being 34% according to one meta-analysis. Depression might be associated with the new onset of or exacerbation of maladaptive behaviors, particularly self-injury and aggression, and a decrease in self-care in the autism population. And so that's one of the reasons that we want to address this. And then depression and anxiety are highly related, and often high levels of anxiety have been shown to predispose depression. So, and then anxiety affects between 30 to 80% of youth with autism spectrum disorders. And then these functional deficits include a greater impairment in social responsiveness, more notable social skill impairment, as well as a negative impact on school attendance, family cohesion, and academic performance. Anxiety is also associated with increased severity of certain autism symptoms, including the repetitive behaviors, the compulsive ritualistic kind of behavior, the sensory symptoms, and just a total autism symptoms. So the rationale for the cognitive behavioral therapy is that it has a huge empirical literature supporting its validity as a psychotherapy approach with typical patients. And so we know that cognitive behavioral works very well for individuals who have depression and anxiety, and that's been validated. Cognitive behavioral therapy can be useful in helping individuals with autism and autism spectrum disorders find relief from these daily stresses while also capitalizing on their strengths. So, for example, being very visual learners, in some cases, logical, rule-governed. So the CBT model really fits well with some of those characteristics. And CBT can address the anxiety and mood difficulties experienced by individuals with autism spectrum disorders, as well as improve their social skills and independent functioning. Those are, areas that are often needing some work as well. So the problem is that autism interferes with key coping skills, and anxiety and depression undermine a person's confidence. So the solution is to build skills and confidence. And the way that we do that is to develop the cognitive and behavioral skills. And that includes coping skills like positive thoughts, emotion recognition, friendship skills, social skills. And then we also want to apply these skills in the real world. And so this is done in vivo in a session, but also through homework with parents or others, where we're gradually facing these feared situations or difficult situations, and developing peer relationships, and then also engaging in those independent skills that I spoke about, the self-help and self-advocacy, and building those independent skills also works on building the self-confidence. So for individuals with autism spectrum disorder, when we're using cognitive behavioral therapy, we're typically focusing on gaining a better understanding of the physiological, cognitive, and behavioral experience of anxiety and depression, as well as the role of avoidance in maintaining these symptoms. Change through implementation of new cognitive strategies to deal with misinterpretation of threats. And then exposure techniques for approaching and reducing reactivity to threat-related stimuli and situations. So who is a good match for CBT? CBT requires that the client processes thoughts verbally. So we want the client to have some sufficient verbal skills and cognitive functioning. I mean, essentially, it's a form of talk therapy, and so even if there's less talking, we're still mediating things using language. And so with writing and with talking and listening, and developing different strategies. So the thing about cognitive behavioral therapy is that we can modify it to be more behavioral than cognitive. And this is helpful with the clients that have a little bit more difficulty with language, and or a lower IQ, low average IQ. So cognitive behavioral therapy really developed out of behavior modification and cognitive therapy. So behavior modification is really the ABA therapy that a lot of the young kids are entering in, as children. And it's become widely used to treat a variety of mental disorders over the past 40 years. So again, this is empirically supported by research. And it's really based on the idea that how we think, the cognition, and how we feel, our emotions, and how we act, our behavior, are all interacting together. And specifically, our thoughts determine our feelings and our behavior. People can learn to monitor and alter their thoughts in order to bring about changes in mood and behavior. And also, changing our behavior can lead to changes in mood in the way that we think about things. So we have this cognitive triangle, and later I'll talk about the importance of visuals, but this is something that I might show clients within the context of therapy. So we've got all of these three things that are interacting. So feelings, what I feel in my head and in my body, affect what I think, which affects what I do. And what I do will affect how I feel and what I think. And what I think affects how I feel and what I do. And that may sound complicated, so we definitely break it down when in the context when doing therapy. But then there's also some modifications of cognitive behavioral therapy for the autism spectrum disorder population. So typically there's a heavy parent involvement, especially for children, adolescents, and young adults. A lot of the young adults that I see are still living at home, or parents are still heavily involved. And so it's definitely helpful to have parents who can carry over some of what we're doing in session in practice. That's super important for these skills to generalize and to become ingrained. And like I said earlier, the use of visuals, so cartoons and images, worksheets, and repetitions in skill presentations. So doing often and practicing. Then part of behavior modification is using rewards, so it's no different here. We want to reward good behavior, and that might include circumscribed interests, for example, as a reward. So, we might incorporate trains or whatever the special interest is in order to motivate this person to do the homework and to practice and to make these changes. So there's also additional focus on social skills training, and that's not necessarily something that we would do with other populations, but with this population, it's definitely important, and we can use these cognitive behavioral methods to teach social skills as well. And then increasing independence and self-care and adaptive skill routines, that's important, again, for the self-confidence, and also for the ability to carry out some of these things in other environments. And then, of course, generalization of skills to other environments. So that's, again, where the homework comes in. It's great if we can get rid of anxiety in my office, but I really need for my client to be able to calm himself down in other settings as well, and generalize to novel settings. So where dogs might have been a fear, at one point, he can use those calming techniques to calm himself down when encountering a stressful social situation. So the common components of cognitive behavioral therapy include psychoeducation about emotions and anxiety and depression, and the 3-component model. Anxiety reduction strategies, breathing, retraining, relaxation, cognitive strategies including flexibility, restructuring, recognizing and challenging those faulty cognitions or thoughts. The exposure strategies, and this is more of the behavioral piece, these are situational exposures and narrative techniques, so imaginative exposure. And then parenting strategies for children through young adults, anxiety, mood education for the parents, appropriate reinforcement during times of high distress, techniques for managing over-involvement. Some of these parents are a little over-involved, and so not really allowing for the patient to experience the anxiety and or depression and then get themselves out of it. And then modeling of anxiety and the appropriate way to manage that. So parents are often models, and we want to make sure that they're modeling what's helpful and adaptive. So the intervention includes using multimodal stimuli, so talking, scaffolded by drawing, writing, photographs, and cartoons, and acting. So again, the visual, I think, is really helpful, especially in this population. I mean, I have paper and markers, and I'm always drawing graphs and anything visual to kind of help solidify the point that I'm trying to communicate. And relying upon the person's special interests as metaphors to maintain enthusiasm and motivation. So, for example, talking about how superheroes face their fears if the child is interested in these superheroes. And children and adolescents and parents are taught these friendship skills like play date hosting, joining peers at play. Parents are taught how to support their children or teens in entering and maintaining conversations or play. And then adults are also taught these interpersonal skills in the workplace, with family members, with friends. And then there's these habit reversal procedures, or what it's called, but we use this for those repetitive behaviors. So using incompatible replacement behaviors. So if someone is flapping their hands, we might want them to put their hands in their pocket because that's incompatible with flapping, and it's a replacement behavior. And then we reward hands in the pocket instead of hands flapping. So, like I said, there are different components and steps to the cognitive behavioral therapy. And with this population, with the autism spectrum population, often these guys have some difficulty recognizing their own emotions, what makes them feel happy or sad, how it feels inside. And so emotions are powerful responses to things that are going on in our lives, and they tell us about what's going on around us and how we're supposed to respond. And so it's important for them to be able to identify their emotions and understand when they're feeling these emotions in order to change them. And so we want to explain the emotions very concretely. So how does it feel in your body when you're scared? Does your stomach hurt? You feel sweaty? You feel hot? You feel sick to your stomach? And how does it look in your face? And so we look at facial expressions like the picture that is on this slide. So, I might say, how does this mother look? Maybe she looks like she is telling him a story. She has a smile on her face. She's looking up at him. And how does the boy look? Well, he looks kind of sad. He's kind of a frown on his face, and he's slumped over. So this is how it looks on his body. Maybe he's getting in trouble. And I typically use pictures where the face is more clear. So these guys are both kind of facing each other. But looking at pictures or videos and identifying emotions in other people, and then being able to identify it in yourself. And sometimes it's more about those physical sensations. If trouble identifying the feelings in your head. So the other piece of the cognitive behavioral therapy, and an important piece, is the exposure therapy and response prevention. So this is a subset of the CBT, and it's often used to treat anxiety and specific phobias. So it involves a systematic and repeated confrontation with fearful stimuli. It's often used in conjunction with relaxation techniques. And then we want to use a hierarchy where skills are taught in these small incremental steps. And this includes teaching social skills, independent skills, and anxiety, mood management. So essentially, if I'm afraid of heights, I want to make sure that I can get up high and calm myself down. So that's the exposure part. If I'm working with a child who's afraid of dogs, the way that we're going to do the hierarchy is maybe just talking about dogs, and then maybe we look at pictures of dogs, so photographs of dogs, and he's got this high level of anxiety just looking at the pictures, and then we get him to calm down. So we're teaching the relaxation piece before we expose. And then maybe we're looking at videos of dogs, and maybe we look at dogs in real life but in a cage, then out of a cage but on a leash, then no leash, no cage. And so there's this hierarchy. And then we're also teaching relaxation and different self-statements. So how likely is it that this dog is going to bite me or hurt me or whatever it is that I'm afraid of? And so we'll talk a little bit more about those faulty cognitions. And so I often show this chart as well. So when the first time that you're shown something that is scary, your anxiety goes up, 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 and then you're feeling anxious for kind of a long time, and then it slowly goes back down. So the second time, it goes up a little bit, but not quite as much, and then it's a much quicker duration, and you come back down and relax more quickly. So the duration decreases, and the intensity of the anxiety decreases as well. Now, if you were to face something that was fearful and then quickly leave, then you're essentially reinforcing that leaving and reinforcing that fear, so you don't get over it. So that's why the exposure is really important. So one of the things that we see, and one of the things that we try to address in cognitive behavioral therapy, are these automatic thoughts. So we all have these automatic thoughts. It's the way that we survive. Based on our experiences, we learn how to quickly sort through huge amounts of information and decide what's important. So if I am in the woods and I see a bear, I need to quickly know to, get out of there or do whatever you're supposed to do when you see bears. I don't want to sit there and take my time analyzing the situation. And so our brains are created to have these automatic thoughts, and they're very adaptive in some ways. And so we develop these automatic ways of interpreting the world. And some automatic thoughts are useful, like in the bear situation, but some are maladaptive, and these are those that end up causing us problems. So we really need to identify and evaluate our automatic thoughts that are causing unpleasant feelings and frustrating behaviors. So there are a bunch of different faulty automatic thoughts, but these are some of those that I see the most in my practice. The black and white thinking, this is just, I think, so pervasive in the autism spectrum population. So thinking that a situation must be either one way or another. There's no gray, there's no in between. So, I'm either going to fail that test or I'm going to pass that test, and it's one or the other. He either likes me or he hates me. There's no in between. Then there's mind reading, so believing that you know what others are thinking without considering other more likely possibilities. Like, I'm doing a public speaking presentation, and I am certain that all of these people are thinking that I look really stupid right now. So I'm reading their minds. I don't know what they're thinking. And so those are the ways that we challenge some of these faulty cognitions. Jumping to conclusions, so thinking that the chances of something bad happening are much greater than they actually are. So if I go out onto the playground, I'm thinking that definitely nobody's going to want to play with me, and so I just jump to this conclusion without actually thinking about possibilities of some people maybe wanting to play. So thinking the worst is telling yourself that the very worst is happening or will happen without thinking of other less negative ways that the situation could turn out. And so, if there's a dog that is on the same sidewalk as I am, they will attack me and bite me. I will end up in the hospital. And that's really thinking the worst. And there are other possibilities, like the dog is not going to attack you, or, there's obviously a whole range of gray in there. And then ignoring the positive, so always focusing on the negative rather than the positive. Like, I'm definitely going to get an F in this class. Well, what about the A that you got on this paper, or the B that you got on this project? What about the effort grade? So just really focusing on what bad is going to happen or in that situation. So then we want to challenge these faulty cognitions and what might happen. And so these are my detective questions. So we want to be like a detective and find out what's realistic here. Am I 100% sure that this dog will attack me and I will end up in the hospital? So if I gather a bunch of evidence, like, what kind of a dog is it? Is it a Chihuahua? Okay, so how likely is it that a Chihuahua could really hurt me? It's on a leash, so how likely is it that the Chihuahua can break away from the leash? So then we go from I'm 100% sure that I'm going to end up in the hospital to maybe it's more of like a 10%, and that's much better. What's the worst thing that could happen? So I'm going to go to a party, and the worst thing that could happen is that nobody talks to me and I feel really lonely. Well, that would be terrible, and would you be able to survive that? What can you do if that happens? Call mom to come get me. If it did happen, could I handle it? So at the party, if nobody talks to me, will I die? No. It will be very uncomfortable, but I will survive. I will make it. I'll be okay. Can I really tell what someone else is thinking? Nope, you can't. There is no mind reading. And how likely is it that this will happen? How many times has this happened in the past? So my parents are going out to dinner, and I'm really worried that they're going to crash and die and not come home. Well, has this ever happened in the past? Have there been car accidents? Is it frequent? No. Is this really as bad as I think? So these are the types of questions that, and there's a bunch of questions that you can ask to really challenge, like, what's going on. The other piece is relaxation. So I find that deep breathing is the thing that sticks the most with the people that I work with. And so I work with children and adults that have autism spectrum disorders, and I do this cognitive behavioral therapy. And the deep breathing is something that you can show visually, like take a deep breath, you feel it like in your abdomen, hold it, breathe out, and you can monitor and control that. The calming positive self-talk you can also monitor because you'll have the person do it out loud initially, and then they'll do it more quietly when they're out in public, etc. And then we have these cool down plans. I mean, this is another option where, okay, if I'm in a situation where I get angry, what is the thing to do? Or anxious or depressed, what is the thing to do? So we develop these plans, and again, visuals. I'm using visuals to really help facilitate the understanding. So, like I mentioned earlier, a lot of individuals with autism have strengths in visual processing, not all of them. And so you obviously have to tailor your therapy to the person that you're working with. But it's pretty common in individuals with autism to have these visual strengths. Additionally, spoken language might be an area of weakness, even if the person can speak in complex sentences and for a variety of purposes. So, you know, there are individuals with Asperger's that have just great vocabulary and language, but when you really break it down, there are these subtle difficulties in their language and even understanding, and especially with the idioms and the sarcasm and that more abstract language. And so visuals just make it much clearer. So we use charts, pictures, even gestures. And then technology also, so smartphones. So we can have a reminder set up on the phone that says, you know, do this, do your homework, or this is the cool down plan, or this is the plan, the exposure plan. And this can all help in teaching skills and facilitate an understanding. So this is my feelings chart. And then with cognitive behavior therapy, we use what's called a SUDS indicator to assess how anxious a person is. And so for this thermometer, we've got like the red, which is very scared, or the most scared, very scared, scared, a little scared, happy, calm, not scared at all. And so there's this visual using this thermometer, and we can have an individual say, okay, this is where I feel right now. I feel very scared that there is a dog on the sidewalk. Okay, so we're going to take deep breaths. We're not going to run away. Deep breaths, dog's there, you're here, and positive self-talk. And then how do you feel now? Okay, I'm a 4, I'm scared. Okay, so we've got to keep going with the deep breaths. We're not leaving the sidewalk until this person's down at a 1 or a 0. And then we repeat. So the practice, repeat, 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 until this patient is feeling success. So here's an example of a cool down plan. So when you're feeling really angry or anxious, what are things that you can do? Well, I can squeeze my hands together like lemons and then relax them. I can take 3 really slow deep breaths in and out, in and out. I can think about happy things like playing my video games or on the computer or relaxing in bed. I can think about lying in the sun and looking up at the clouds. I can think to myself, stay calm. It's going to be okay. I will try. My heart is slowing down. I can talk to a safe person like my mom, my friend. I can tell her how I feel using words. I feel like a 4. I need a break. I feel angry. I want to take a break. And so a 4 would be on, you know, a scale of how angry I feel. I can take a break and I can get a drink of water or go for a walk. So for this individual, having these visuals and this plan, you know, we could create this little card that he could carry around with him. It's laminated and used as a reminder. And that way, when he's with mom and feeling angry, mom can just break out the card and she doesn't have to use a lot of language to help him calm himself down. She's got this card, and He's got all of these strategies that he's practiced within session. So much of the change is occurring between sessions, and how quickly the individual attains their treatment goals is really directly related to how often and completely the homework tasks are fulfilled. And so this is where the parents come in. And I've talked about the homework throughout this presentation, but it's where it happens, and it's how we generalize these skills. So, we want to get it. So it's happening consistently within the therapy session, and then we bring the parents in and say, this is exactly what we did. I need you to do this over the week, and let me know how it goes. So finding the right therapist. I think that number one is that experience with Asperger's disorder, high-functioning autism, the PDD, NOS. And those are the diagnoses that we're typically going to see in cognitive behavioral therapy. You want a licensed mental health practitioner who has experience delivering CBT. So that might be a licensed psychologist or mental health counselors, social workers, marriage and family therapists. And I think that it takes someone who can be creative and think outside the box, especially with this population. And you want the patient to develop a good rapport with the therapist. And I think that what helps in that respect is for the therapist to have empathy for the client and have a really good knowledge of how autism works and how it impacts everyday living. Someone who understands and is not judging them on their deficits. So you can contact your insurance company to find out about therapists, but I would recommend contacting your local CARD for referrals. So there are not very many people, I think, that specialize in this area.